we would ever get over 50 people for these calls. So that's awesome. It did take us a couple weeks to actually get our cap lifted. So sorry for everyone who was having a hard time getting into the calls, but thanks for your patience, and I'm glad you're all here today. So Jesse, you can hit the next slide for me. And one more slide. You guys will probably all remember we have talked about how in the off months, every quarter we're going to do an in-person leadership council meeting. It'll be more of sort of a regional touch base on all of the different elements of work that are happening between the different county collaboratives. At this time, the collaboratives are still sort of forming. We have sent out a request for MOUs. Those are due at the first week of April. So really by mid-April, we should know who the participants in all of our collaboratives are, and we'll be moving towards getting those collaboratives meeting regularly and starting to develop their own transformation plans. The Spokane County Collaborative is having their first sort of informational orientation meeting today after this Leadership Council meeting, so that starts at 1. And I know a number of you are going to attend that too, and to make sure no one has to spend all day long with BHT, I'm going to do everything I can to get this call to end a little early. Jesse, next slide. So what we are going to talk about today, my ACH update, is on some of our ACH region-wide measures. So the slide that I have up right now is sort of this what is success slide that we've been using throughout, all of our orientation and collaborative presentations. On the left, in the blue boxes, are just a few of the metrics that ACH partners are going to be tied to as we work through our projects. So these are the metrics that we will earn dollars for if we're successful in moving the needle on these measures. There are, of course, many more metrics. These are a handful of the ones that are statewide. On the far right, you see we have these collaborative health outcomes. Those are the health outcomes that we expect to be determined by local collaboratives. We want to have each county give them the autonomy to decide that there might be some health outcomes that are specific to their community, to their counties, that they really want to focus on. This is largely in hopes of honoring the fact that a lot of, especially in our rural counties, we had pre-existing rural county health coalitions that are now sort of transitioning into collaboratives, but a lot of those have been meeting about things that were true to their own communities that may not fall directly into the ACH work, or there may just be elements that they really want to incentivize and work through in their own communities. So those will be determined later once the collaboratives form. But what we're talking about today is this column in the middle, the ACH local measures. These are sort of region-wide measures for the whole ACH. And the idea behind this was that while the metrics on the left and the huge list that goes along with them, they're very specific to the projects that we're going to pull off, and they're quite technical. A lot of them really exist solely within a clinic walls. When we look at some of the things like child visits, antidepressant management, a lot of these things are going to really be involved just in a clinic setting or maybe in a care coordination setting, and they don't necessarily translate to overall community-wide transformation. The BHP wanted to set...
Hadley?
Yeah.
Hadley, this is Jack. I forgot to mention this. I just want to break in and ask everybody if you could please mute your mics. That would be really helpful. Thank you.
Thanks, Jack. All right, that's a little better. Thank you all. So as I was saying, BHT wanted to sort of identify some region-wide goals for transformation that are a little bit more inclusive than just the very specific metrics that we're looking at for waiver dollars. Now, some of these measures you've probably seen before. We've done a handful of presentations on them. We did last fall a webinar-only Leadership Council conversation on these measures, kind of having a conversation with a handful of folks about these measures and sort of your response to them all. That was really helpful. And I've given this presentation at one additional Leadership Council meeting and to some of our board members. So you can actually see those meetings recorded up on our website if you're curious about some of the conversation that we've had that has informed all of these, informed our decision on these measures. So really, what I want to do today is sort of walk through these 4 measures and what we mean when we're talking about them. At the last board meeting in February, the BHT board sort of approved these 4 goal areas and gave their seal of approval for BHT to start making some recommendations for how we might find activities that align with meeting these goals. And if anyone has any questions at any point in time, feel free to pop them in the chat, or I will pause at the end, or we'll make sure everyone's unmuted and we can have a conversation. And Jesse, if you can hit the next slide, I'll start walking through some of these measures. All right, so the first one we were looking at is reducing unintended pregnancies. One of the reasons we looked at this metric is you all will remember that back in the day when we got the toolkit, it had 8 projects that BHT could choose from. 2 of them are required, that's opioids and bidirectional integration, but otherwise we got to pick up to 8 projects that we could take on as a region. In the beginning, BHT was pretty excited about doing all 8. We were definitely thinking, let's go big and go home. Let's do the whole, make as big of an impact as we can. And the way the funding mechanism works at that time, it seemed that if you took more projects, you'd be eligible for more dollars. And some of you will remember a little bit later, we found out there was a reduction in the funding, and that kind of changed our decision. We wanted to make sure we were more focused and applying for what we knew that we could be successful on in order to earn the maximum dollars. And we didn't want anyone in our region feeling like they were spread too thin among too many projects. So that influenced our decision to pick the 4 projects that we're looking at now, which are bidirectional integration, opioids, chronic disease, and care coordination, which is the use of the pathways model. Now, the other 4 projects included transition and diversion strategies, and then reducing unintended pregnancies, really focusing on maternal and child health, and then also an oral health access project. It was a pretty hard decision for the board to not include those projects, especially because there's a whole lot of need in our region. It's also just from a moral perspective pretty hard to turn away, say no to a maternal and child health project or an oral health project, and we know there's such need for oral health services in our region. So the board made a decision, and when they approved those projects, they worded it in the motion that where possible we would look to incentivize strategies from the other 4 project areas within our work so that we can make sure we have the maximum impact. Calling out reducing unintended pregnancies as a goal area is sort of honoring that maternal and child health project that we did not end up selecting. Additionally, maternal and child health was one of the sort of early priority areas that came up in interest when we had our first year of community discussions. Some of you remember the population health strategy map group that met, and one of the target areas was reducing unintended pregnancies. And we had some really great conversations, and it's exciting to me that we can sort of keep that goal and move it forward through the ACH work. So up on the screen, you'll see just some examples on the left of where some of the need is. I was pretty surprised to find that 35% of pregnancies in the BHT region are unintended, and we have a pretty high rate of teen pregnancies, so I do see a definite need here. We also see this in parallel with some of our other projects, especially projects having to do with care coordination and and behavioral health. We know that women with a chemical dependency experience, half of those women end up with 4 or more pregnancies. So we can see a great intersection between sort of our target population of looking at pregnant moms, also looking at folks with behavioral health issues. There's also a lot of community effort going on right now around reducing unintended pregnancies that we have a big opportunity to align with. There is a foundation called Upstream, which has made Washington State sort of their home base for the next couple years, and they're going to be doing pilot projects here in town, working or across the state, working with clinics to increase their strategies towards getting same-day access to birth control and reducing unintended pregnancies within their patients. So we intend to partner, sort of work alongside Upstream to see how we can make an impact. We had hoped to have them on the call today to give a short presentation about their work. However, we had the last minute. That's going to help you all get out of this call early, but we'll also try to have a follow-up with them so you all can get to know their work. Women of a childbearing age and pregnant Medicaid moms for a target population in the future, probably in 2019, after we've sort of built out and got the Spokane County Jail Transitions Project off the ground. So I'll pause there really quick and see if anyone has any questions or comments on reducing unintended pregnancies for an ACH goal. you may have questions about how we got here, or if you just have ideas for ways that we could sort of align with this goal, I'd love to hear what your thoughts are.
Hadley, this is Jack, and it's not so much I guess it's a more general question with these projects that are outside of the ones that have been identified as part of the ACH Healthcare Authorities approved project plan. How's the funding going to work? We've talked a little bit in the past about sort of funds flow to the collaboratives for projects. How do these particular additional ones fit in?
Yeah, great question. And I probably should have covered that first because my intent was to cover it at the end, but I'll just give you all a quick update. So we, after the board had approved these 4 measures for the ACH, we took them to the Waiver Finance Council last week. The Waiver Finance Council is sort of responsible for making recommendations to the board for how funds are allocated for ACH work. And they gave VHT the thumbs up to sort of make a recommendation for allocating funds towards these activities. So I don't have any details right now because we still have to put forth this recommendation, but we're sort of imagining that it will look like, so in the bulk of our projects, VHT is going to be making some sort of setting requirements. Imagine sort of a framework for a menu of what options you have to choose from when you're looking at projects. An example is, so there's a bidirectional integration is one of the projects. There are a couple of strategies put forward. One is the BRE collaborative, it's also the collaborative care model. And VHT is sort of making some setting recommendations for, if you are a behavioral health provider, then we are going to recommend you use this model and incorporate XYZ elements into your plan. So we think that we will be looking at strategies and activities around these 4 goals, and then give our collaborative partners the option of taking on those activities and earning some incentive dollars for those activities. And again, we still have to put forth our recommendation. So I'd be happy to hear, thoughts from the group as we go through this, but that will be coming in the future. Does that help, Jack?
Yes, thank you so much.
And I see a couple folks have some hands raised in the virtual chat. Both Cindy and Jenny have your hands up. Do you guys have questions?
Yeah, this is Jenny. So I do have a question, and it's maybe more for clarification. I just want to make sure I understand this correctly. So you're just showing the reduces unintended pregnancies as an example of a metric that VHT is still going to focus on, although it does not fall under the chosen 4 projects. That's the first part. And then the second part is when our collaboratives meet and determine, some of the other measures that we want to work on locally, that if those do not fall under the additional projects that VHT has selected, they will not be eligible for incentive dollars.
I don't think that's necessarily entirely true. We also haven't quite. Oh, I'm going to ask if someone else can mute your phones.
Okay.
Hey, Hadley.
Yeah.
This is Allison. Do you want me to weigh in on that?
Yeah, sure. Sorry.
We have not. That was my hollering in the background there. We have not made a formal decision on that, Jenny.
Okay.
What the Finance Committee has sort of agreed to was the ACH level, and it is my intention in our recommendation to both recommend a funding model for the ACH priorities, and then if local collaboratives have additional ones, that we would put forth as a recommendation, because I think we really do want to honor the very specific work that is happening at a local level. And I also wouldn't think you're going to fund that work with these dollars to a large degree. I think it will be a small amount that really just reinforces the local control that we've tried to build into our process.
Awesome. Thank you.
Thanks, Allison. All right, not hearing any questions, I'm going to move us along to the next priority area. All right, so the next one we're looking at is increasing behavioral health access rates. So this is sort of a no-brainer with, first of all, there's a heavy emphasis on behavioral health throughout all the project areas we're looking at. But additionally, there's a huge amount of need in our region. We know that pretty much across our region, we're underserved in behavioral health access, both for substance abuse and mental health treatments. So, a major goal for us in transformation is to see that by the end of 5 years, we've significantly increased access for our region. You can see here our, substance use penetration rates. This data all came from the Healthcare Authority. It's only about 25%. So that says that the people who have an identified substance use disorder need, of those people on Medicaid, only 25% of them are getting their care. And for mental health, it's not looking too much better at about 40%. And then we also see, this just breaks my heart, 35% of 10th graders in our region report feeling so sad or hopeless nearly every day for 2 weeks in a row that they stop doing a usual activity. So we know that this is a problem that is continuing on into the future. We have a lot of young people who are going to be growing up with mental health issues and behavioral health issues, and we want to make sure that we have a system that's ready to welcome and support them. So aligning efforts with this, outside of the projects that are happening within the ACH work on themselves, we've been excited about some efforts throughout the region to scale, add some more resources, add some more beds for mental health and substance use disorder. We're excited about things like the Rising Strong. There's a lot of family reunification strategies happening around town, and a huge increase in awareness and emphasis on trauma-informed care. I think that this gives us an opportunity not just to talk about, access and intervention, but also sort of community-wide, how can we support a culture of recovery and really start to reduce the stigma associated with mental illness and substance abuse. And I think that's a necessary part of the sort of culture shift that's part of transformation work. And I'll pause here once again in case anyone has comments or questions on behavioral health access. All right, and Jesse, if you can move me on to the next slide. All right, so our next priority area we're looking at is reducing jail recidivism. This has obviously been a big interest area for BHT since we started our SIM project, doing jail transitions through the Pathways Hub up in the Ferry County Jail. We've been lucky enough to have some folks ahead of us across the nation doing Pathways work. A similar program in Michigan doing jail transitions with Pathways saw recidivism rates for 2-year parolees drop from 46% to 17.7%, so nearly 20% drop, which is pretty incredible and gives us a lot of hope that the work that we will be doing connecting folks as they transition out of jail to supportive services is going to reduce recidivism rates here in our region. We will be aligning this closely with the work of the Spokane County Law and Justice Council as we work through the Spokane pilot for Pathways. Through their MacArthur and Smart Justice grants, they have a requirement to track recidivism rates as well, so we'll be working alongside them as we sort of figure out how to tackle this. Any questions on jail recidivism? All righty, next slide. All right, so our fourth priority area is looking at increasing oral health. So we, again, BHT since our beginning has had a high interest in supporting oral health access through the DENT program. And now we see there are a lot of efforts going around through the region to increase oral health access, both through sort of the clinic level. We see a lot of our FQHCs are growing dental chairs. We have the oncoming Providence Dental Residency Clinic, which is going to do a lot of great work for our region. And then a lot of interest in sort of community-based oral health programs. So things like sealants in schools, are, oh, a little echo there. But yeah, so there's been a whole lot of community alignment around oral health. And I'm excited this is going to be a good segue because we'll be introducing Maureen and Jerry, who are here with us from Smile Spokane and the ARCORA Foundation. We're going to give a little presentation on the Spokane Oral Health Local Impact Network and some work that ARCORA is doing across the state and especially in some counties here in our region to make sure that we have increased access for Medicaid patients. So I'm not going to talk too much about their work because I don't want to steal the show. But here I will pause and see if there's any questions on oral health, any ideas for oral health, or any questions on the last 4 priorities in general before I kind of wrap up with what the next steps for these are. All right, Jessica, can you hit the next slide for me? All right, so as I said, the waiver finance group sort of gave us a thumbs up to consider some funding allocation options for this. So the BHT staff, in partnership with some of the technical councils, is going to be starting to build sort of a recommendation for how we'd actually want to measure these different goal areas and how we would want to allocate funding towards them. So we'll be working probably closely with the Provider Champions Council, Community Voices Council, a number of our technical councils that sort of have an advisory role for this, and look through how do we want to define these metrics, build a recommendation for what sort of activities might be attached to them that we could task our partnering providers to take on if they're interested, and then figuring out how much funding would be available for these activities. We are also really interested in exploring how we could tie these 4 areas into our Community Resiliency Fund. You'll all remember that we are holding a portion of our dollars each year to go towards this Community Resiliency Fund that could be put towards some of the, maybe region-wide issues or barriers that we see, especially coming from the social determinant side, that are barriers to care in our region. So we'd like to explore how we can tie some of these goals in with funding opportunities through the Community Resiliency Fund. So I'm going to pause there one more time and see if anyone has any thoughts, comments, or questions that they would like to voice on this. I'd be really interested in just a quick discussion if anyone has ideas for other elements happening in the region that could align with some of these goals. And once we finish with that, I'll be transitioning over to Maureen and Jerry. All right, well, thank you all. We will be, as usual, these slides and the recording will be available after the presentation if anyone wants to sort of revisit some of the stats that are on these slides. And with that, I see we have Maureen on the call. Maureen, are you ready for me to transition over to you?
I'm ready.
Awesome. So we will have your slides, and Jessie will just go ahead and move them forward for you if you can let her know when. Everyone, I'm really excited to introduce Maureen. ARCORA has been a really exciting partner to have here in the region. They're doing they've taken a really big interest in Spokane County, and I'm excited to share a little bit more about their work. So Maureen, welcome to the BHT Leadership Council.
Thanks. Hi, everyone. Thank you so much for having us. I'm going to talk a little bit and then hand it over to Jerry Allard, our partner at Smile Spokane. So Jessie, if you could go to the next slide. So we're going to talk a little bit about what the data tells us. Many of you have probably heard some of this data, but I think it's really important to ground ourselves in what the challenges around oral health and what the data tells us. So we'll do a quick review of the data, and then we'll talk about what we think some of the solutions might be, and the alignment with the work that Better Health Together is doing, and would love to get your input on this work as well. So next slide. So looking at sort of current oral health status, we know that tooth decay is the most common chronic disease in childhood. It's 5 times more common than asthma. And we know that nearly 40% of kindergartners in Washington state have tooth decay. And why is this really important? This is really key because kids miss school because of poor oral health. They can't focus, they can't eat properly, and all of this tends to lead to sort of issues going into adulthood. Another sort of common oral disease is called periodontal disease, also referred to as gum disease. So almost half of U.S. adults have some form of gum disease, and this actually gets worse as we get older. So when we look at adults in middle age, 1 out of 5 adults have some form of severe periodontal disease. When we look at Washington state, we know that 1/3 of seniors have lost more than 6 teeth due to decay and gum disease. And this is key because Medicare does not cover oral health. There's no dental benefit related to Medicare. So we have a huge segment of the population not necessarily focused on in the Medicaid demonstration, but it's key, I think, when we think about sort of the population at large in need of oral health services. When we look at the BHT region, we know that there's higher rates of tooth loss and reported pain in the mouth compared to other regions. Next slide. So this slide, it can be difficult to read, but essentially what I want to point out is the sort of Medicaid enrollees that have had at least one dental service in the last data source we have is from 2015. And so the blue line, the top line, is percent of child enrollees. So we know across Washington state that about 55% of children are accessing the dentist at least once a year. We have the second highest rate of children accessing the dentist in the country, which is kind of crazy when you think that it's still only about half of kids. So we're still missing half of the population. With adults, the situation is a lot worse. Only 22% of adults on Medicaid are able to access the dentist. And there's a whole host of kind of barriers, but a few being the cost is really high. So there are a few covered benefits under Medicaid, and there are not a lot of dentists that actually accept Medicaid insurance. And so the foundation and Smile Spokane are working on both of these issues. Next slide. So this just highlights again the challenges around children's oral health. So the thing that is really striking about oral disease is that it's almost entirely preventable. So the fact that we have so many children that have oral disease is, it's really sad. So we know that nearly 1 in 6 third graders suffers from rampant decay. And again, this is really key because it leads to chronic pain and infection. And all of you know, if you're in pain, it's really difficult to focus and to get your work done. There can be difficulty speaking, eating, learning, and then also self-esteem issues. And the self-esteem issues, I would say, cross the lifespan with not just children, but for adults as well. It can be very challenging to get work if you have oral health issues. Next slide, please. So this demonstrates the changes in oral health looking at the decay experience related to low-income preschool children. So these trend lines are not going in the right direction. So we know in 2010, for example, the decay experience of low-income preschool children was around 33%, and in 2015 it was measured at 44%. And when we take this data and look at it next to the fact that utilization rates have not really changed, so they're right around that 55% mark, we know that something's going on here, right? Like, we need to do more than get kids to the dentist, which is one really key piece of the puzzle. But I would argue that there is a prevention gap that we're not addressing for these children. Next slide, please. So I wanted to spend a minute talking about the ARCORA Foundation and what we do. So I just presented a lot of data, and our mission, the ARCORA Foundation's mission, is to bend the arc of oral health towards equity. We are sponsored by Delta Dental of Washington, and we work across the state. We're actually working with all of the ACHs across the state to integrate oral health into the portfolio of projects and work that the ACHs are doing. So it's looking different in different ACH regions, and there's different challenges. So I want to move into kind of what we see as some of the solutions and how we see working with Better Health together. Next slide, please. So what's the problem we're trying to solve? We know that there is a prevention gap. Both cavities and periodontal disease are almost entirely preventable chronic infectious diseases. And there's right now just an unacceptably high burden of the disease. We know that dental care is reportedly the most common unmet health need across Washington state. And right now, the health system, as it's set up, does not reach these populations with the highest burden of disease. So often we have folks showing up in the emergency department seeking treatment for oral health needs that can't be met in the emergency department. And something else needs to happen in order to reach these populations. Next slide, please. So when we think about the accountable community of health and better sort of value-based outcomes, there's kind of three buckets that I think we can think about as it relates to oral health. So one is quality of care. And a few of the activities I think that fall under this particular bucket are fluoride varnish for children and adults that are at risk for oral disease. So fluoride varnish is actually a grade B recommendation from the U.S. Preventive Services Task Force, which is a group that recommends activities that take place in primary care that are evidence-based. And it also ensures that providers get paid to perform these activities. So in Washington state, all providers are paid to do oral health preventive services, including fluoride varnish for children up to age 6. Sealants for children is another one of these quality of care issues. We know that it's one of the best ways to prevent cavities in the molars. And so this is another just sort of quality of care issue, ensuring that children receive sealants. And then the third is around adults screened. So in primary care, ensuring that adults are being screened for oral disease and being referred to the proper care as identified. The second bucket is around population health. So looking at how do we know sort of the health of the population, the oral health status of the population across the population, if you will. And we don't have a good handle on that right now. I just showed you a lot of data that relates to kind of decay experience and utilization. But what we don't know is kind of are populations getting healthier over time. And so the foundation is working on doing some research, developing what we're calling severity profiles around cavities and periodontal disease. And something I didn't mention earlier, the reason this is so critical is that, as you all know, through oral health is related to your overall health. So if you have diabetes or elevated blood sugar and you also have periodontal disease, it's going to be a lot more difficult to manage your diabetes if you have out of control periodontal disease. An analogy I like to use is if you had an infection on your arm, your primary care provider would not ignore the infection, they would treat it. And the same goes for oral health. If there's an infection going on in the mouth, folks need to get that treated. Otherwise, it's going to affect overall health. The third bucket around paying for performance or value is around utilization and risk. So looking at, is there inappropriate ED utilization around oral disease? And then the second is around anesthesia use for caries and kids, which essentially is a measure to say, we're having to put kids under anesthesia to treat really severe dental decay. Next slide. So why is this important? I think because in order to transform into a system of care, we really need to start looking at these performance measures. Mostly right now, dental care is delivered in a procedure-based environment. And as I said earlier, there isn't a good way to measure the health of the population over time. And until we start doing that, we're not going to be able to get to a system where we're paying for value. I also think there's a need to promote healthy habits. In general, public polling shows that people value oral health, but there's a disconnect between behavior and what people say. And then lastly, I think there's a need to really eliminate health inequities and disparities. I didn't have time today, but there's some really good data across the state that looks at oral health disparities across populations. And we need to start to look at how we eliminate those disparities. So with the goal being that we want better health for everyone at a lower cost. Next slide. So right now I'm going to hand it over to Jerry, who's going to talk about our work in Spokane.
So good morning, everyone. This is Jerry Allard. I'm the local liaison here with Smile Spokane. I'm going to talk a bit about Smile Spokane and the work we're doing with our community partners to improve oral health, and then I'll hand it back to Maureen to wrap us up. So Smile Spokane, it's really a partnership of multiple organizations that was formed in 2015 with the purpose of championing strategies to improve oral health. And at that time, much of our work was focused on community education and awareness of the importance of good oral health and the connection between oral health and overall health. And this work is especially important for Spokane, given that the level of fluoride in our water is inadequate to prevent decay or dental caries. In 2017, Smile Spokane expanded into a more comprehensive approach using a local impact network model, expanding to 7 strategies led by our community partners, with the overall goals being to increase access, to champion upstream solutions, for example, prevention, and 3, systems transformation. We're working with medical dental systems. We share many of the goals with BHT and the ACHs across the state and are committed to mutually reinforcing strategies and aligning our efforts wherever it makes sense. And I also want to note before I go to the next slide that it's really important to note that this work would not be possible without the commitment of our clinical and community providers. They're really the ones carrying this torch. That Smile Spokane is simply the organizing entity, providing the backbone support and coordination, and leveraging our network to champion the work of our partners. So the next slide, please. So this slide is a little busy, but I'm going to talk about it a bit. And it's really the catalyst for this presentation of how we organize this work. And those of you that have been working with us for a while know that we started with a very busy bubble chart, and this is what it has morphed into. But what this slide does is kind of capture how we're organizing this work. So starting in the left purple box, you'll see our care coordination strategy with Aging and Long-Term Care of Eastern Washington as the lead organizations. So the 7 strategies there are listed in the blue or the purple boxes, and I'll just be talking about them a little bit. And then Maureen's going to go into the care coordination strategy a little more in depth because we see opportunities for alignment there with those of you on the call here today. So the care coordination strategy really works to outreach and support our medical and dental providers, care coordinators, managed care organizations, and Medicaid beneficiaries to provide people with diabetes and pregnant women with oral health care, with enhanced benefits for those eligible, and starting in 2019, increased reimbursement for participating dental providers. So moving on to the next one on the left, the community solutions to the opioid crisis. Not the next slide yet. Thank you, Hadley. This strategy is really beginning to take shape. We had a number of meetings just yesterday. Actually, the health district here in Spokane is taking the lead on this strategy for us, working closely with Better Health Together and others to work with the dental community and other stakeholders to identify ways to enhance prevention, treatment, and recovery in support of efforts to reduce opioid-related mortality. And moving on to access, the third strategy is oral health integration into 100% of primary care. And ARCORA Foundation is the lead on this strategy. The strategy works to provide training, tools, and technical assistance to medical teams to address their patients' oral health needs. We're encouraging integration of oral health into health profession training programs and collaborating with the ACHs and care delivery systems to support integrated medical dental care and population health. And here's the access one. So this strategy is increasing access to dental services, and our target is by 200% for adults on Medicaid and for seniors, with Providence Health being our lead on this strategy. And this strategy seeks to double the current rate of access to oral health services for adults enrolled in Medicaid and for seniors by identifying and implementing evidence-based or other innovative models for significantly increasing access. And moving on to the fifth strategy, and that's our school sealant program in the schools where the majority of students are enrolled, and free and reduced meal programs. And this is led by Communities and Schools. And Communities and Schools works closely with two savers to provide the services to the students, working with the schools and the partners to ensure that 100% of these students in the target schools receive the sealants, and importantly, they are connected to a dentist for continued care. Then next we have our care linkages strategy, with Frontier Behavioral Health being our lead entity for this strategy, working to provide care coordination and support to connect people experiencing mental illness to dental care. And then the seventh strategy is led by Smile Spokane, which we work here to communicate the benefits of good oral health and the connection between oral health and overall health, using digital media, our website, along with many other community education opportunities. So that's a very quick rundown of our 7 strategies. But I want to mention what's not on this slide. We have 2 key components here, and that's our clinical implementation committee and our evaluation team at the health district. So in addition to our 7 strategies, we are also working very closely with a clinical implementation team that consists of representatives from the dental and the medical community that bring their clinical expertise to this work. They offer guidance and feedback on the strategies from their clinical perspective. And then our data measurement team, we are working closely with the team at Spokane Regional Health District to develop and monitor a measurement model to measure the work that we're doing. We want to make sure that our goals and strategies are directed at the primary drivers of poor oral health. So with that, I'm going to hand it back to Maureen to go a little more in depth into our care coordination strategy.
Thanks, Jerry. So if you could advance to the next slide. So this is that box that was on the left. This is kind of a further explanation of what we mean when we're talking about care coordination. So we are really looking at how do we make sure that oral health is integrated into community-based care coordination systems. And so the green boxes there that you see are all the kind of partners and resources that are going into this. And forgive me if you don't see your organization or you're not identified here. There are more than we can list here. What I want to point out are two really key pieces of this work. One is oral health connections, and that is one of the green boxes you see there. Oral health connections is a program that was brought on by the legislature this year that is going to pilot a concept of connecting patients with diabetes and pregnant women to oral health care. That's Medicaid insured patients with diabetes and pregnant women. And it's going to be piloted in 3 communities, and Spokane is one of them. So we are in the stages of planning for a January 1st, 2019 launch of this pilot, which will work with local dentists and care coordination entities and medical systems to ensure that these populations get connected to care. We have contracted with RDA, which is the research arm of DSHS, to help us understand what the cost savings are going to be as a result of this project. The foundation is really excited about this work because we know that there is a heightened need for oral health services for those particular populations. And it also, the timing is really, really good with the ACH work and the focus on chronic disease and pregnant women. So that's one thing I wanted to point out as part of this strategy. Aging and long-term care and the health district are leading the effort related to oral health connections. The other piece I wanted to point out is a tool called Dentist Link. And for those of you who haven't visited the website, I would encourage you to. It's dentistlink.org. And this is a web-based portal that connects anyone to a dentist, whether it's commercially insured or Medicaid or uninsured. And it's being led by the ARCORA Foundation right now. And we're doing a lot of work to ensure that patients have a seamless experience getting connected to care. If any of you all have looked for a dentist and you have Medicaid insurance, you understand the huge challenges in sort of sifting through the hundreds and hundreds of providers that are listed on the Healthcare Authority website. Often the patient experiences that they call multiple providers and find that they're actually either not accepting new patients or not accepting any patients at all. And so what DentistLink does is sort of automate that experience. Folks are generally connected to care via text message if that's what they opt into. And if they are a patient that needs a little more support, they can also get that through DentistLink. So it becomes like an automated experience, but also customizable for patients who might need that experience. And our hope is that DentistLink as a tool can really help to smooth some of the referral processes that will need to happen through oral health connections and the other sort of care coordination that we're hoping to build into this particular strategy. Next slide. So how are we going to know if this works? So I think, similar to the accountable community of health, there are metrics that we are holding ourselves to. So, and what I would say is these are really performance metrics that we are going to be tracking. So, for example, connected to the sealant strategy, we're going to be looking at, do we have an increase in percentage of low-income children that are receiving school-based sealants? With the idea that that's then contributing to a decrease of low-income children with untreated decay. Another example would be related to the access strategy. Do we have a decreased percentage of avoidable ED visits that are for oral health reasons? Are there an increased percentage of dentists that are billing for services provided to Medicaid clients? With the idea that this is then contributing to a decrease of adults and seniors with decay related tooth loss. And then the last example is around medical dental integration. So if we have an increase in percentage of primary care healthcare providers billing for oral health services, we hope that there will then be a reduction in countywide costs for publicly funded restorative dental work. So that's a snapshot of how we hope to evaluate this work over time. Next slide. So we're really hoping that these are the work that Smile Spokane and the Accountable Community of Health under the umbrella of the Local Impact Network, that this work is really mutually reinforcing, that these anchor strategies are really meant to accelerate the work that Better Health Together is doing. So what we have committed to is to develop some shared communication tools and messages as to not confuse our partners in this work. We are looking at, as Hadley said, exploring including oral health measures in required activities for providers. I'm sure that this group will be hearing more about that as those get developed. There's definitely synergy around emergency department diversion, looking at the opioid work and the task force, looking at how we integrate medical providers into this work, making sure that patients are referred consistently to dental care, so including patients with diabetes, pregnant women, and other sort of at-risk populations. Really ensuring that oral health is a key component of care coordination systems, and would love to hear from this group other ideas for where there is overlap in the work and other ideas that you all have. And before we do that, I have one last slide. If you could go to the next slide. So this is really busy, but I like it because it shows kind of the efforts that, so you can see on the left-hand side, there are the projects listed there. And we know that Better Health Together is focused on bidirectional integration of care, care coordination, opioid, and chronic disease management. And so I think when we look here, I've talked a lot already about a lot of these examples, but there are, I think, real opportunities to really reinforce and accelerate the work within all of those projects. If we make sure that we focus on oral health and, as we at the foundation like to say, put the mouth back in the body. So thank you for listening today, and would love to hear your ideas about how we can continue to work together on this issue.
Thank you so much, Maureen. If anyone has questions, you're all off mute, and I'll be looking at the comment box too if anybody wants to type something in. All right, going once.
So Hadley, I see there's someone has a question about the sealant program.
Yeah.
So I can speak to that. The sealant program is really, so there's evidence that shows that if you place a sealant on child's molars at specific points in their life, that it can have a lifetime sort of preventing cavities. And so there, that is where this goal around having sealant programs in schools with more than 75% or more of kids on free and reduced price lunch comes from. The work is being led by communities and schools and being executed by a school-based sealant program under the name of Tooth Savers. And essentially the model works where hygienists go into schools and place the sealants on clean teeth. Essentially, if there's any active decay, the student is then referred to the dentist for cleaning and treatment. And that in a nutshell is how it works. Are there more specific questions about the particular program?
Sorry, I was muted. I asked a question about the sealants program. So my name's Dr. Luis Manriquez, and I work for the WSU College of Medicine, and we're currently doing our needs assessment for mobile clinics, and this came up in our conversations with communities and schools. And I was interested to know, how is this being funded? Because I feel like that is something that could easily be connected to the work being done with a mobile clinic. And once you have a kid in for sealants, you could also make sure they're up to date on immunizations and so on.
Mm-hmm. Yeah, so the way that the sealant programs are funded is that the hygienist actually bills Medicaid for the services. So it's a reimbursable service from Medicaid. And then what we didn't talk about is the foundation's kind of investments in the local impact network. So I would say we're sort of in the process of identifying kind of where there's additional resources needed. I will say it's been amazing. This work has sort of taken off and started with some investment in the lead anchor strategies, but we haven't given out any grants. I'll put that in air quotes yet. We're really thinking of this more as a partnership, and so. But the foundation is committed to investing in resources with the idea that this is a scaling and sustainability strategy to sort of infuse resources in the community in a way that will increase prevention and access, but with the idea that within a few years, the foundation is reducing investments and the activities are sustained within the communities. So Luis, I think if you want to talk more, I'd be happy to talk more offline about where there might be synergy between the mobile van and what we're doing.
Yeah, that'd be great. Thank you.
Okay.
Are there any other questions for Maureen or Jerry? And we will make sure these slides are sent out in the recap so you all have them. All right, well, hearing silence, I think that I've met my goal of letting you all out early. I will make sure that we share the slides and everything in our recap, and I'll also include Maureen's contact info, so if anyone is interested in getting a hold of ARCORA, they have the ability to do that if you'd like to talk more about oral health strategies. Maureen and Jerry, I just want to say thanks for being our guests today and sharing the good work you are doing, and we are really excited to be aligning as much as possible to increase oral health in our region.
Thanks, Hadley.
And with
Thank you.
And with that, these slides will all be posted. Next month in April will be our next in-person Leadership Council meeting. So we are working on an agenda that hopefully will give everyone time to get some face time connecting with folks from different counties and sort of see how the work is progressing and who's really at the table as we started to build out these collaboratives. So I'm really excited to have us all in a room again together once we get to April. And with that, I will see some of you this afternoon at the Spokane County Collaborative launch, and I hope you all have a wonderful Wednesday.